Next, I would like to invite our esteemed keynote speaker, Nkwain Ngamfon, to the stage, President and CEO of Wound Masters Incorporated. Wills leads Wound Masters, which is a mobile practice delivering care to those unable to visit hospitals. His commitment to aiding those suffering from chronic wounds has seen Wound Masters grow exponentially, successfully treating thousands of patients over the past decade. Please join me as I welcome Wills to share his views in the expertise on the topic living and managing wounds.
Good morning, everybody. So, my goal this morning is going to be to raise awareness for people and families that are managing wounds. In fact, there are 6.7 million Americans suffering with wounds. These are the ones that are diagnosed. 6.7 million Americans. And in the UK, there are 3.8 million people who suffer from wounds. So hopefully this morning, by the time I will be able to run through this, we shall be able to handle basic wounds that happen in our families and are not diagnosed by physicians. So we are at Wound Masters Medical Group in California and Wound Masters Mobile Physician in Arizona. How we started, why wound care, and the concept of mobile wound. I'm going to just tell you a short story of what happened. My mother lived for 87 years with a heart condition called atrial fibrillation. So when I finished college, I asked my mom, I had lost my dad, so I asked mom, what next? So mom wanted me to come to America and study something that will help her heal her heart. When patients live with atrial fibrillation, basically you have to be on blood thinner and some heart, medications. My mother lives for 87 years with none of those. So when I finished college, mom said, please, my son, go out there and help me when you come back. So she found a scholarship. I came to America. The goal was to come in and study about, cardiology and a few more things that could go back to Africa. I come from West Africa. So when I finished school, I had known about the treatment that my mom needed. And so I picked up a job in medicine reconciliation. I wanted a quick job so I could get her some money, get medication, take back home, so my mother could live longer. So I picked up this job in medicine reconciliation. Basically, what I was doing was I go home, take care of patients, reconcile, because there's a lot of polypharmacy right now going on. So patients don't want to go to the hospital. That's the first thing I noticed. A lot of patients don't want to go to the hospital. Of course, they feel that going to the hospital, they are abandoned by their families. So I go home, take care of these patients, reconcile their medications. By the time I'm leaving, they'll call me, hey, don't come back. My legs are swollen. I don't know what this is. So I will just think about maybe increasing the dose of their water pill and I'll go home. Other patients will say, I have this rash on my back. I don't know what is happening. They call it rash. So I kept on getting this, and I will refer some of them to the hospital. They don't want to go to the hospital. So after a few months, I decided to go visit my mom. I had worked for a couple of months. So I called mom. I told mom, I'm coming home, and I'm bringing some medication. In 2 weeks, my mother developed a stroke. The following week, she lost a lot of weight, and before I even got my ticket, my mom died. So I traveled home, and by the time we're getting ready to, prepare her for funeral services, I noticed that my mom had a big hole on her bottom, and that was a wound. So when I came back to America, I started paying a lot of attention to those patients who had been telling me about rashes on their back and the lower legs and stuff like that. So Wound Masters was on behalf of my mom, and I do this with passion. I have passion treating patients with wounds. Any patient that I see, I'm treating the patient thinking of my mother. Now, that is how we started. Now, what are the benefits? Some of the benefits of doing this. Basically what we do, we hire a lot of physicians. Right now we're in California and Arizona. We zone the physicians. They come to we train them. We train them with the same passion that I develop, with treating patients with wounds. So we train them and we zone them. We put them in areas all around California and Arizona. When patients develop wounds, we have a marketing team that goes out there and look for patients with home health and hospices that need wound care. So these physicians, they commit to patients' home, do debridement and do treatment for the wounds. And we've been doing that. We've healed thousands of patients with diabetic wounds and pressure ulcers. So basically what we're doing is bringing the hospital to the patient's home. So today I wanted us to, by the time, I want to raise some awareness so that by the time we have family members that have wounds, we should be comfortable handling those. So I'm going to be looking at two kinds of wounds. There are tons of wounds: pressure ulcers, diabetic wounds, arterial wounds, malignant wounds. But I want to take a look at two main kinds of wounds. Like I said, the population of patients in America living with wounds is over 6.7 million. That's about 2.5% of the population of America. So majority of these patients are older generations. Now, how do these wounds happen? Wounds generally happen on areas that are in contact with hard surfaces, the bed, the chair, anywhere where the patient is in contact. Those areas are known as pressure points. So it could be the back of the head, could be on the shoulders, could be on the hips, could be on the bottom, heels. Those areas that are in contact with the bed or bony prominences, those are the areas that wound will happen. So if we are living with our family members that have wounds, it is important that we start monitoring them and seeing how they lay in bed, how they're eating. A couple of things will cause those wounds. And we have a lot of risk factors that we can be looking at. Patients that are advanced age, older folks, there are a lot of things that happen when we get old. We don't eat enough, we don't drink enough, and so the muscle mass generally thins up when we get old. We become anemic. Patients that have anemia will also have a high risk of developing wounds. If patient becomes contracted, contraction simply means that the patient has limited positions to move. Contracture is a big thing in developing wounds because patients cannot reposition properly well. Patients with decreased mental status, Alzheimer's, dementia, sometimes they forget themselves and they're able to lay whole night without having that feeling that that part of the body is in pain. Other risk factors will be patients that have developed pressure ulcers in the past. If you have developed pressure ulcers in the past, it is possible that you can develop more wounds as you age. Patients with limited mobility. If patient is not able to move properly well, it's a high risk that can develop wounds. Patients that have spinal cord injury, they're paralyzed, it's a risk factor. Patients that have they're losing weight rapidly. If you lose weight rapidly, it's a very high risk that, of course, if you're losing weight, you're not eating properly well, it's a high risk that you can develop wounds. Now, other things that are risk factors for developing wounds is urinary incontinence or fecal incontinence. Feces, urine has a very high pH, sometimes 6 to 6.7. When it gets in contact with the skin or with an open skin, it would basically just eat up the skin. And another factor is fragile skin and friction. Shearing, moving the patient with very thin skin is a high risk that the patient can develop wounds and the body opens up. So what are the early ways to intervene? If you find a patient or your family members that has that the body becomes red or has a high risk of developing wounds, how do we intervene? First thing to do is to put the patient on some form of cushioning. Patient laying in bed for too long. There are several forms of cushioning that are available now on the market. Gel cushioning, hospital bed generally. Some mattresses, they're known as group 1, group 2, group 3. These are all mattresses that will offload the patient because pressure ulcers are caused by weight, pressure, contact between the body and the bed. So we're trying to offload them by providing those foams and those mattresses that will take off pressure from the patient. Now, it's important too that we know how to stage wounds, because wound staging equates how you deal with the treatment. So there are 4 categories of wound or staging pressure ulcers. There's stage 1, there's stage 2, stage 3, and stage 4. In stage 1, it's just the skin being red. It's full thickness. There's nothing lost. Maybe patient is incontinent, spent the whole night not changed, or maybe in contact with feces or urine, the skin becomes red. That is stage 1. In stage 2, there is partial thickness loss. The epithelial tissue is lost. Because when the skin becomes moist over a long period of time, overnight, you might have that epithelial tissue that is taken off. And that is stage 2. Stage 1 and stage 2 pressure ulcers can be treated at home by everybody. How can we do that? We can intervene by offloading, making sure that the patient is being repositioned every 2 hours. Make sure that you're moving the patient. If it's laying on the right side, make sure you keep moving every 2 hours. We can also treat this by exposing to air. Air heals a lot. When patient is exposed to air for a couple of minutes and the skin was completely red like it's seen in stage 1, it heals normally. Another way is to control incontinence. Make sure that the patient doesn't stay overnight in contact with urine and feces. And the third and final way is to use what is called skin barrier cream. We have Caroceptin, we have A&D, and a couple of them. So stage 1 and stage 2 could be managed by anybody. But when the wound gets into stage 3 simply means that some tissue of the skin is lost and we're getting into the subcutaneous part of the body. When wounds get to this level, they will need some intervention by a wound specialist. This is stage 3 in subcutaneous. Stage 4 means that the bone could be exposed, that the muscle could be exposed, and that the tendon could be exposed. With stage 3 and stage 4, we need some specialty to get in there and take care of the patient. So how do we take care of this? Surgical debridement is what we do at the bedside. We will debride the wound, take off the necrotic tissue, take off the slough, and make sure that we apply the agent that will be able to heal the patient. But the patient has to be offloaded rapidly. Secondly, we make sure, because when the body is exposed, there's a high risk that it becomes infected with bacteria. So infection control is very, very important. We do this at bedside. And then we also make sure that we apply agents that will either take off the drainage, because when wounds are healing, they're either draining or some of them could be dry. So we heal wounds by balancing moisture, applying agents that will either take off the drainage, either by using wound wax, by using alginate. There are a couple of wound care products now on the market that we can be able to use. So that's how we take care of stage 3 and stage 4. Now, some wounds that have not been debrided, covered completely with necrotic tissue, are known as unstageable wounds. These wounds when we visit the patient, we need to see how deep they are. So these ones are called unstageable wounds. Either it's covered by necrotic tissue or they're covered by sloughy tissue. So wound care is very, very common. It could be done at home. We advise that stage 1 and stage 2 could be managed by family members, but when it complicates, it is important that they call the specialist in to take care of them. So, what about diabetic wounds? Diabetic wounds basically are wounds that are caused by high sugar in the body. Now, high sugar, when patients are suffering from diabetes, it's either because the insulin is unable to be controlled, or he doesn't produce enough insulin. Long-term diabetes causes peripheral neuropathy, which means that the patient begins to lose sensation in the lower extremity. When you lose feelings, most often diabetic wounds happen in the lower legs, those on the plantar surface of your feet. There is one of my friend who called last week, and the dad had been coming back home with a long nail that got into the shoe, and every time he gets up in the morning, they see a lot of blood in the shoe, in the shoe, and they were not aware that he had a nail. So later on, two weeks after, he went to the hospital, and they had to amputate. This is because when patients have diabetes, long-term, they have what is called diabetic neuropathy. And most of the diabetic wounds happen through trauma, patient not having the feeling, and the wounds happening, and before you know it, the wounds are either at the point where they have to amputate. Now, treatment of these wounds, like I said, is through debridement. Most of these wounds, long-term diabetic wounds, might cause arterial wounds too. Arterial wounds complicate into gangrene, and gangrene equates amputation. So early debridement and placing the patient on antibiotics to control infection may be able to save the patient's limbs. Another way of controlling this is to have the patient on early amputation. Early amputation saves a lot of patients with diabetic wounds. So most of the ways we intervene is to control infection, make sure that we debride the wound properly well to healthy bleeding tissues. We advise the primary care to put the patient on some form of diabetic shoes to offload, because patients sometimes they develop these wounds unconsciously without knowing. And early amputation, like I said, and reconstruction of the blood vessels. So, diabetic wounds, I thought I should talk about diabetic wounds and pressure ulcer, but there are many other kinds of wounds, like malignant wounds that we encounter on the field, arterial wounds, venous ulcers mostly happen for patients that are retaining fluid in the lower legs. And treatment of venous ulcer will be to do some form of multi-component dressing to address the veins that are unable to have a venous return to, and then putting the patient on a water pill. So I guess this is what I had for my discussion this morning. But basically, we do more than just what we had this morning, because we have providers, doctors that are specialized in wound care, and they move around. Educating the family is a very, very important thing. Talking to the family about repositioning, helping the patient control their diabetes, making sure the patient is feeding properly well, making sure that friction is reduced when you move the patient. It's very, very important. Patient education for wound care is really big. So thank you so much, and hopefully it gave some help to those who are having family members with wounds. Thank you.